Thank you very much, Dr. Preet and the team for inviting me. And I will be talking about cancer-specific mortality in T1a renal cell carcinoma treated with local tumor destruction and versus partial nephrectomy. So as we know that renal mass less than 4 centimeter up to is called as small renal mass T1a, and it represents all over the 3% of all malignancy and accounts 90% of renal solid tumor nowadays. And the peak incidence is 50 to 70 year with man to female 2:1 and more into the Scandinavian countries. But now the RCC is increasing because of the attributed widespread use of cross-sectional imaging. And most of the lesions now detected are the small and they are localized. So they have the better long-term outcome, and although the mortality rate is declining subtle. So as you know, the treatment option, the partial nephrectomy or the ablative local tumor destruction, that is a cryoablation, radiofrequency ablation, microwave, and minimal invasive focal therapy. But as the previous paper, SBRT is right now not into any trial or into the guidelines to comparison as a local treatment of renal mass. So there was a EAO panel who compared the outcome, and finally they conclude that effectiveness of local tumor ablation to the partial, and they recommend that tumor ablation should be only done in the frail or the comorbid patient with small renal mass. But if we see the study, the initial study, when the minimal invasive partial nephrectomy versus laparoscopic cryoablation for newly diagnosed, so we found that disease-free survival at 5 years was 92% in partial nephrectomy, while it was 93% comparable into the local tumor ablation patients. But it's really difficult to match exactly what are the patients, those who are we are taking to the partial nephrectomy account or as per into the local tumor ablation. Then the further trend patient did the multiple long-term survival with cryotherapy in the partial nephrectomy for small invasive national cancer database using propensity cross matching, in which they have matched all the groups of the both side, and the total cases of 1,19,240 cases they have found, and the cryotherapy was done in 927 patients in 2009, 13, and 2012. So finally, after the matching, they found that it is comparable with the cryotherapy was lower with as compared to the partial nephrectomy. So again, regarding about the morbidity and mortality, 30 days mortality rate was less than 2%. Either we do the local tumor ablation or the partial nephrectomy, and overall complication rate was 21% after local tumor ablation as compared to 40% into the patient of the partial nephrectomy. So then what we take the message in this, the local free recurrence, the metastatic free survival. So this is the study which head-to-head comparison about the cancer-specific mortality into the T1a with this. In this, there was whose number of the cases from 2000 to 214. The best in this study they have done, they have taken 1:1 ratio propensity score matching about all the patients who are underwent the local tumor ablation with all the modality and versus the partial. And what they found, that is a 10-year cancer specific mortality rate was 8.7% versus 5.5% in multivariable study. And it was cancer specific mortality was higher in local tumor destruction as compared to partial nephrectomy. And then they further divided these two subgroup in the tumor less than 3 centimeter and tumor with 3 to 4 centimeter. So what they found, if we compare the outcome in response of cancer specific mortality in the patient, those who are in the less than 3 centimeter, they found that 10-year cancer specific mortality into the partial nephrectomy was 5.3, while it increases to 7.2% in the patients who has been treated with local tumor destruction. And but when we take about the tumor which are 3.1 to 4 centimeter, it increases 6.1% into the partial nephrectomy patients and more into the 11.4% into the patient who have underwent the local tumor destruction. So to conclude this study that taken together, it is local tumor destruction is associated with 1.5-fold higher cancer specific mortality related to the partial nephrectomy. The magnitude of the cancer-specific mortality disadvantage probably increases if the tumor is bigger. It is more than 3 centimeter, 3 to 4 centimeter, 1.72-fold higher as compared to the tumor if it is less than 3 centimeter. And these observations should be considered as a clinical decision making and for taking the informed consent for the patient that despite cancer-specific mortality inferiority, local tumor destruction may be a viable option in the patient in which you require the renal preservation or the surgical patient is not fit for surgery. It's like life expectancy decrease or the is not fit for the surgery. Thank you.
Thank you, Dr. Vikas.